My name's Chris Seder. I'm the chair of the General Thoracic Surgery Database Workforce for the Society of Thoracic Surgeons. We presented our most recent data looking at over 32,000 patients who had clinical stage 1A non-small cell lung cancers that were 2 centimeters or less. And those patients underwent a number of different operations, some lobectomies, which is the most common operation, and some sublobar resections, which include both segmentectomies as well as wedge resections. And our question was really, in the real world, and when you look at surgeons operating in clinical practice, do sublobar resections actually provide as good of an overall survival benefit that as you see on trials? Now, there have been a couple of different trials that have recently been done, and they're landmark studies, and this and they said that they concluded that sublobar resections and lobectomies were essentially equivalent, or sublobar resection is not inferior to lobectomy. Well, so we wanted to study this in the real world, not on a trial basis, and see if we found similar results. And what we found, surprisingly, was that lobectomies actually did better than sublobar resections. And that seems to be primarily driven by the wedge resections, not necessarily the segmentectomies. So the wedge resections had significantly worse outcomes. They had less lymph nodes sampled. They had more positive margins, and they had less nodal upstaging, suggesting that the nodes weren't sampled as well. And so, based on this, we've really concluded that these data are not at all contradictory to what the CALGB 140503 or the JCOG trial have said, but in fact, they're complementary. And right in the discussion of the CALGB trial, the authors state that unless you follow the exact trial protocol that is described in the study, which might include taking lymph nodes at the time of surgery, making sure that all the margins are negative, and very strict patient selection criteria, you can't expect the same results as you see in trials. Some people have wondered if we're showing that wedge resections don't perform as well in the real world as segmentectomies or as lobectomies, does that mean that we should just send all of our patients who have wedge resections to radiation or SBRT? And I don't think that that's the case at all. In fact, there's a couple of things that surgery provides that you don't get from any kind of radiation therapy. One is a good lymph node dissection to adequately stage patients. The second is definitive pathology, whether that be needed for making the diagnosis or for next generation sequencing. It's important to have a good piece of tissue to work with when you're thinking about future therapies. Now, there have been a number of trials that have been opened and closed early for small tumors, comparing surgery to focused radiation. And I think that if nothing else, you could take the data that we've presented this weekend at the Society of Thoracic Surgeons annual meeting, and it should be a call to action to our medical oncology and thoracic oncology teams to not only consider putting patients on trial, but try to really figure out what is best for these patients, especially high-risk patients, and see if we can answer that question. We know that these data are quite powerful and informative. I mean, this is the largest database study that's ever been performed with survival linkage to not only the CMS data, which is the Medicare data, but also National Death Index data. And we have up to 10 years of follow-up. So we do believe that this is important information, but you have to realize that, this is a retrospective data review. And so we can't answer all questions about exactly what patients should get a wedge resection, what patients should get a lobectomy. What we can say is you should follow trial protocol if you want trial results. And what I think you can also say is that this study suggests that the CALGB does not give free rein to any surgeon to just perform a wedge resection on any patient who has a sub 2 centimeter non-small cell lung cancer. There has to be a bit more that goes into it. And what that bit more is, the study, can't necessarily define, but we have some ideas. It may mean making sure that all of your margins are adequate. It may mean that you have to take enough lymph nodes. And that's what, we suspect is the case. We looked at both overall survival as well as lung cancer specific survival, and found that all of the findings that we identified with our overall survival analysis all held up in the lung cancer specific survival analysis. And so we believe these findings are real, and the data are starting to guide us a bit on what's happening out there as we do different operations.